Hi everyone, it's Dr. Krad. One of the most rewarding procedures in all of medicine is removing a white cataract. Here is a patient with a mature white cataract. The patient is blind in this eye. They only have light perception vision. The pupil response is great and brisk, and so the prognosis is great. For this patient, I'm using a laser to create the capsulorhexis, fragment the cataract, and perform a limbal relaxing incision, or LRI. In this case, I'm using the new LENSAR Ally laser system, and you can see the capsulorhexis, the separation of the nucleus, and the LRI at 1 o'clock. I performed the patient's corneal incisions manually because overall I think the corneal incisions the laser creates are not as good and less predictable than my own incisions. I typically don't perform B-scan ultrasound in cases where the pupil responds so well. The pupil response is quick, there is no APD or afferent pupillary defect, and the history is not consistent with a retinal detachment. This patient's history is consistent with progressive cataract growth. And so in my opinion, a B-scan ultrasound is unnecessary. We can remove the cataract first and then we'll get a good view of the retina. I would only perform an ultrasound preoperatively if I suspected a retinal detachment. Just let the patient know beforehand that you're unable to assess their retina until after the cataract is removed. And so you don't know if they have a retina issue like macular degeneration or a macular pucker. I stain the patient's capsule with trypan blue and remove the pre-cut anterior capsulorhexis. The ink marks at the limbus were placed just so that I can properly place my limbal relaxing incision. I'm filling the anterior chamber with dispersive viscoelastic and removing the air bubble. And the capsulorhexis is not free floating, and so I need to watch out for capsular tags. Now I'm going to create my main incision at the limbus, and I will create a triplanar incision. I do this with a 2.4 millimeter keratome, and in my experience, this type of incision is better than a laser incision. Laser incisions look very good. They're always exactly the same in terms of their size and architecture, but they're not always placed at the appropriate position along the limbus. And as you can see, there are a lot of tags here. So I need to be very careful on how I tear this. I'm going to use my forceps to remove the anterior capsule in a tangential fashion so that if there are any large tags, I decrease the risk of them propagating. So I'm going to tear this away just like I would a manual capsulorhexis. Most of the time, I find that laser capsulorhexes are free floating, unlike this one. However, there is a higher risk of radial runout with femtosecond laser capsulorhexes. After releasing some viscoelastic to make sure I don't build up too much pressure in the anterior chamber, I gently hydrodissect the cataract from the lens capsule. But look how beautifully round and perfectly centered this capsulorhexis is. After hydrodissection, I will rotate the lens to make sure it is free and decoupled from the capsular bag. I think the laser could have done a better job at the capsulorhexis to make sure that it's free floating, and it could have done a better job separating the cataract into quadrants. But this is a new laser, and oftentimes when you start using a new laser, the settings have to be modified to optimize efficiency for each of the surgical steps. Here I am carefully separating the cataract into 4 quadrants, and it's coming apart fairly easily. In this case, I'm using the Centurion phaco device, and I'm just using torsional energy, about 80%. I'm not using any longitudinal. Now that we have the cataract separated into multiple pieces, we're going to pull out each quadrant one by one. We're going to make sure that we protect the corneal endothelium. I'm going to phaco-emulsify each piece in the iris plane. I'm using my second instrument to try to prevent the chattering pieces from hitting the corneal endothelium. When you remove the first half of the cataract, the priority is to protect the corneal endothelium. And that's because you have a chunk of cataract holding the posterior capsule back. You see this last piece here is holding the posterior capsule back. However, when I pull this piece forward, now there's nothing protecting the posterior capsule, so I have to use my second instrument to protect that posterior capsule. With mature cataracts like this, you'll see there's almost no cortex. there are just some wisps in the capsular fornix, but that shouldn't stop you from trying to remove those cortical wisps in the periphery or stop you from polishing the capsule. Here I'm searching for cortical material in the periphery. I'm trying to see if there's any loose cortex that will come to my aspiration tip. I'm doing this very carefully, of course. My cortex settings are very conservative. They start at 0 and linearly increase, so I can control it just like polish mode. After removing any wisps of cortex, I polish the anterior capsule, I polish the posterior capsule, and for any lens material that I'm unable to get out, I will then power wash with bound salt solution. So now that I've finished polishing, I'm going to use the bound salt solution and I'm going to irrigate into the fornices of the capsular bag. And I will do so from my main incision, and then I will power wash from my paracentesis. I'm just trying to get the capsular bag as clean as possible. And then here's a trick I learned from another YouTuber. I'm going to give him a shout out. His name is Tariq. Let's see, hold on, let me just double check. Tariq Yusuf. He does really efficient cortex removal, all with a J cannula. I mean, he doesn't even I and A. He just uses the J cannula and flushes out all the cortex. Everything comes out so quickly, it's amazing to watch. But it just happens all so fast, so I haven't switched to that technique. But I do use the J cannula to remove stubborn subincisional cortex. And you may think I polished enough, but that's my weak point. I like to polish a lot. So after filling the capsular bag with viscoelastic, I use the sweep polisher to polish the posterior aspect of the anterior capsule. I can easily shave off a minute or two from each one of my cases if I just don't polish so much, but I just love the way the capsule looks when it's so clean. Alright, finally, after boring you guys to death with my polishing, I'm going to insert this patient's lens, which is a Bausch & Lomb Aspire lens. Of course, there are lots of good monofocal lenses out there. I like that this lens platform has eyelets, since they can be used if you have a situation where you need to suture the lens. I like that there isn't a bulb at the end of the haptic. I love that the haptics don't stick to each other upon insertion. It opens in a very controlled fashion. And I don't know if it's my imagination or not, but I feel like patient complaints about negative dysphotopsia has gone down since switching from the iHands. If this lens was preloaded and available as a 3-piece, it would be perfect. Next, I'm going to remove all the viscoelastic. And even though this is a monofocal lens, it's important to center it well. Especially in advanced monofocal lenses, to get the optimum performance, you got to make sure that you are centered on the patient's visual axis. It may make a small difference, but why not take it? Now all that's left is to return the eye to its natural state. I will hydrate and seal the patient's incisions. I hydrate the sides and then I hydrate the roof, make sure it's watertight, and I hydrate my paracentesis. I'm going to stress test the incisions, make sure they are sealed, and make sure the eye pressure is normal. Being able to help this patient go from being blind to seeing well is such a privilege, and I'm so excited for this patient. I just watched this video online, and this guy who went to med school and finished his internship quit medicine, and one of the reasons was he didn't feel he was making a significant difference for patients. I think he went into internal medicine, and he was young and new, and so he lacked confidence, and I feel at the very least he was impatient about the kind of difference he can make. But if he was in a rush, he should have went into ophthalmology, because within 10 minutes you can take someone who's blind and make them see again. It's the best field in medicine. You can really change someone's life in an instant. So this patient went from legally blind to seeing the next day, 20/25, without glasses, and he's not even fully healed yet. As always, thank you so much for watching. I appreciate your attention. I'll catch you on the next one. Peace.